Yes, my talk was about contemporary lessons from Old Therapies, because we've been managing pH for a lot of years, but continue to learn and to do a better job with the old treatments that we have, even though those treatments are not perfect. The three key points from the presentation today, and I focus just on some new insights. The first is recent work showing that the use of pyridoxine, vitamin B6, at the very high doses needed in primary hyperoxaluria patients are indeed very safe. Even when they're given for many, many years, they do not cause any serious side effects. It was very reassuring and new information. The second had to do with the effect of medications to reduce crystals in the urine and the kidney of calcium oxalate, thus reducing stones and also reducing damage to the kidney over time. And we looked at data from the Rare Kidney Stone Consortium pH registry, and were able to gather enough data to show that both citrate and orthophosphate have a clearly protective effect against new stone activity in pH patients. And also talked about some data, some early evidence of some protection against long-term kidney damage. And the third was to highlight a new insight into transplantation. And that is a new situation where we, and my colleague talked about it in his talk this afternoon. We did a liver transplant in a patient with type 2 primary hyperoxaluria. Up until now, it's been felt that that's not a disease that's solely in the liver, but other body tissues. So liver transplant had not been done for that disease. But this particular patient had some other features and serious other problems that led us to consider a liver transplant, and it was successful. And after the transplant, now a year out, his urine oxalate is normal and his urine glycerate is normal, and he's not having more stone problems. So that tells us that in the future we can target liver therapy as well as other therapies in pH type 2.